I'd like to welcome everyone. We're going to give it just 1 minute so that everybody can get signed on before we get started with our first webinar today. Okay. Looks like the attendee list has slowed down a little bit. So welcome. My name is Ann Rossich. I am an associate professor at the Johns Hopkins Bloomberg School of Public Health. I'm here to welcome you. This is our first webinar in a series of 3. This is the global effort to reduce the burden of cervical cancer. What will it take? Today, we are going to focus on an overview of the global initiatives in cervical cancer control. We have a wonderful lineup of speakers. We're going to first start with Julie Terode, who is the Director of Special Projects at UICC. Next, we're going to have Dr. Isaac Adewole, who is the former Minister of Health from Nigeria. And then we're going to have Marlene Temmerman, who is the chair and professor at Aga Khan University in the Department of Obstetrics and Gynecology. They're each going to give a presentation, large, focusing on what these initiatives are, both from an organizational level and then also their role in the efforts. Each presentation will be about 10 minutes, and it's going to end with a question and answer session. So I encourage all of the participants, as you have questions for the individual presentation, to please submit those in the question function on the side of your screen, so that by the time we get to the Q&A at the end, we'll have had a chance to read through all of those questions. I think with that, we're just going to dive right in so that we have plenty of time for all of our speakers. For those of you who are interested, CME credits are available for this webinar from Boston University. If you registered for these credits, you'll receive an email after the webinar about how to claim those. So with that, I'd like to pass it over to the first speaker today, which is going to be Julie Terode, as I said, from UICC, who's going to do an overview of the global initiatives focused on cervical cancer control. Julie?
Thank you very much, and welcome everyone. It's a great pleasure to join this exciting series on cervical cancer elimination at a time where we're really now at the cusp of pushing forward at national level. I've been asked to give you an introduction to the Global Cervical Cancer Control Challenge. I'll give you some updates on the progress of the WHO strategy and where we are on that as far as approval is concerned, and touch on some initiatives to take the work forward. But I think my first take home for you is that the global strategy that's now really being proposed by WHO means that every country can eliminate cervical cancer. And I really encourage you to get that message out to your key stakeholders in your own countries. So let's take a short step through the journey to today. Your cervical cancer is a preventable cancer, but it's one where we have such great inequities, both between countries and also within countries, and that's very easily seen in this Iarc map of global incidence, which is the most current data in GlobalCan 2018. And you can see that the deep purple with the highest incidence is over 26 per 100,000 women. But in fact, in many areas of sub-Saharan Africa, we're much beyond that. And they contribute most significantly to both the high incidence of almost 600,000 new cases every year now of cervical cancer, and over 300,000 deaths. And we know that 9 out of 10 cervical cancer deaths are in low middle-income countries. So massive inequities that we really need to address. And particularly in sub-Saharan Africa, that's driven by the double burden of HIV and non-communicable diseases. And we know that women living with HIV are 4 to 10 times more likely to progress, to get HPV and then also to progress to cervical cancer. So it's a key group we need to think about. Well, WHO has a life course approach to cervical cancer control, and we've known this for a number of years. We have the primary prevention opportunities, the secondary prevention opportunities, and the tertiary prevention opportunities. We've had global guidelines from WHO for a good decade or more. Global indicators were embraced in the non-communicable Communicable Disease Global Action Plan. And in fact, that plan also recommends each of these interventions based on cost effectiveness. So you do have to ask ourselves, what's taking so long? Why is nothing happening? And quite often we hear in reports and papers, it's all about the women, but blaming women not seeking help when it's very difficult for them to access care. We hear about stigma and myths and misconceptions in the community, but really, are we addressing those in a women-friendly manner? And we hear about women presenting late, but is that really the problem of women themselves? So I think the three core stories of the global strategy as we move forward are one around equity of access. And we'll hear a bit from Marlene later about integration and how that can be taken forward to really embed this into a women-friendly approach to cervical cancer prevention and control. And we'll also hear from Isaac later about improving access and timely treatment and care, so that we really look at the quality of that care and the outcomes of the care to really drive the elimination agenda. So I, for one, I'm very grateful to Dr. Tedros, the Director General of WHO, to take this personal leadership. And this call to action really came from him as he joined WHO as the Director General. And he didn't only just talk about it, he also brought all of these UN agencies together, some civil society groups together to really try and confine cervical cancer to the history books. And I think that's a really inspirational way about how we can take this forward nationally. It takes strong leadership. So whilst tasking his team to think about what that strategy would look like, there was a double-pronged approach, and also working through with member states about how we could get this topic on the agenda. So we actually in 2019 attended the executive board asking member states to support the idea of elimination and request WHO to develop this strategy. And that was supported by over 70 member states, which was great to see from all geographies. They also tasked WHO with holding comprehensive consultations in each of the regions, and that informed both the strategy and coming back to member states this year in February with a strategy which was revised based on that consultation, but also a supporting resolution. And that was supported, co-sponsored by 50 countries, which is quite unusual to have that many countries supporting a single resolution. There was consensus achieved around that text in February, but of course COVID-19 did somewhat disrupt the World Health Assembly, and the meeting in May became a virtual one and was focused only on the COVID-19 agenda. But member states were very keen to make sure that this current agenda wasn't lost. And so a silence procedure was adopted to take the agenda items forward that couldn't be discussed in May. Our agenda on cervical cancer elimination was one of those, and I'm pleased to share with you the news that that silence procedure has been closed. So that does mean that we are looking at formal adoption of the resolution. So we're actually just in waiting mode. In the next few days, we hope we will hear from both WHO and Australia as the championing country behind this agenda item, that the formal adoption is secured. And then we can celebrate this, get the news out to the key stakeholders and start to think about how to take this forward nationally. But what about the content of this global strategy? Well, in parallel to the policymaker discussions, experts were consulted and this strategy was developed. Starting with this vision of a world free of cervical cancer. And that's quite an aspirational goal for WHO to embrace. And so I really do applaud that. Experts were consulted and helped define the threshold for elimination, which is achieving 4 cases of cervical cancer per 100,000 women each year. That's quite a low incidence, and it takes the incidence below that definition of a rare cancer, which is around 6 per 100,000 or 10 per 100,000, depending on which countries you look at. So we're really talking about confining cervical cancer to the extent of a rare cancer. And what I think is also very aspirational, but also a great challenge to put in front of us, is to also give us 10-year targets to work towards. So by 2030, there are 3 targets that we're encouraging all countries to adopt, which includes 90% vaccination of girls by the age of 15, 70% coverage of screening with an HPV DNA test, and we'll be hearing more about the new technologies in the later series, by age 35 and by age 45, so at least 2 screens in a lifetime, more if that's applicable in your country. And then most importantly, focusing on the follow-up of screening, making sure 90% of women do get the follow-up if they have positive outcomes of that screening, and also making sure women that do present symptoms are followed up for treatment, diagnosis and treatment, and palliative care. So these are a great 3-pronged approach to eliminating cervical cancer. And importantly, it's also linked into the Sustainable Development Goals, which are delivering in 2030, and contributing a 30% reduction in mortality due to cervical cancer in this next 10 years. And it's important because it links us into that aspiration of the SDGs of leaving no one behind and looking at universal health coverage, so financial protection for these prevention and control services. Oh, I had a little bit of a blip there, sorry about that. I run through this quite quickly because I'm assuming a lot of people have seen it before. But there are 2 great papers describing this work now available in the Lancet, which I've referenced below. This light blue line is the current situation in 78 low and middle income countries, the extent of impact of their vaccination and screening activities. It's almost flat, and that's because it's not because we're not doing anything. It's just that we're not impacting beyond the rise in incidence of cervical cancer. So it's like running on the spot. And this is why those aspirational targets are so important. What we're showing is if we increase the vaccination coverage, that we really can bring that curve down. Each time we're bringing that curve down, we are saving lives, reducing incidence, reducing mortality. And so you can see that within a 100-year time frame, we're getting down to very low incidence of cervical cancer. But when we add screening to the vaccination mix, you can see that we're getting a very much earlier decrease in mortality. It's coming down much lower, much earlier in this next 30 to 40-year time frame. And actually right here at the end, we're really bringing it down to low levels in all countries, which with some countries will struggle alone with vaccination to get anywhere near elimination. So this is the basis of those 3 targets. And what I really like, I heard at the consultation in Africa, is that whilst they are aspirational targets, the region of Africa is recognizing that they will uniquely benefit from getting onto this pathway, getting up to those 2030 targets, and starting to take this journey down this curve. So I think we should all be very bold in taking this forward with our policy makers. And I'm including this, it's the same curve really, but just to emphasize that we're not waiting 100 years to get to elimination and then we can celebrate. We are saving lives all the way along this curve. And there's some data here on the side, which I can't see because I've got my my index at the side here, but we save 50 million lives in those 78 million, low and middle income countries by 2030 if we try and get to these targets early enough. And within the next 100 years, we can avert 70 million cases of cervical cancer and 62 million women's deaths due to cervical cancer. These are massive numbers, and I think we should all be very excited about this opportunity. So now I've done something to my slides. Okay. So how far are we on making commitments? Well, Australia is the lead country as far as the initiative for policymakers and member states is concerned, because they've made a commitment nationally. And this is just a small graphic from Karen Kempfel's team, which shows the predicted time frame for when Australia might actually be able to hit that 400,000 level. And they think they could make that in the next 10 to 15 years. And they're currently predicting 2028 might be their year for hitting elimination. Well, the US is very excited to be the first and wanting to beat Australia. And competition is always a great thing. And so good luck there, US, in doing that. Canada's also very optimistic that 2040 they will hit elimination. And in fact, they had a summit on World Cancer Day in February this year, looking with stakeholders around the country to say, could they actually press that timeline and get to elimination by 2035? And I think that's a great initiative to think about how you can bring stakeholders together and say, how are we going to embrace this goal and really make the most of it for pushing our national efforts forward. Other countries have made commitments. Zambia's made a public commitment supported by their head of state, President Lungu. We've had great support, political support in Malaysia, and a public commitment to Malaysians to embrace elimination, and other countries like Kenya, Bhutan, and Rwanda have done the same. So now we're at the cusp of the strategy and the resolution being adopted by all member states around the world. It's a great opportunity to really push and say, well, what does that mean for us nationally? How can we make a public commitment so that our governments are making commitments and holding themselves account to their populations moving forward? And so I'd love to talk about that when we get to our discussion. So just briefly to finish, because I'm sure I'm running close to my 10 minutes, just a few examples of building momentum. There's some great groups coming together to think about regional advocacy, technical assistance, and sharing best practice. We've got an ECHO platform in the Indo-Pacific region. We've got a Francophone African group. We've got a European set of stakeholders really pushing policymakers to push hard on elimination. We have a PAHO task force looking at elimination, and I'm sure there are many more. But I think I would just use this to sort of emphasize that you can work regionally to really move the agenda forward and share best practice and use that peer pressure at the regional level as well as global level. Here's an example of a great initiative in Brazil, bringing different stakeholders together to really get that national reach. And we've got professional groups coming together with civil society and advocacy groups to really embrace elimination and take it to all parts of the country. And I think that's an important story, especially when we're talking about the equity issue. First, actually knowing about this is an equity issue as well. And this is a great example of how that could happen in your country. I think one of the key things is thinking about the new opportunities, the new technologies. And I include this example of Malaysia here, who in partnership with a group from Australia, have really committed to leapfrogging some of the old service models that really weren't having the impact that they wanted. Bringing in the self sample and the ability to link that in with the HPV DNA test and use an e-health solution to really help women navigate that process, make it a very women-centered, women-friendly option. And of course, partnerships at national level, at community level, to really bring the momentum behind elimination. There's a great example of Kenya where they've only just introduced HPV screening. They're really trying to scale up, HPV vaccination, they're really trying to scale up their screening, really working on the mother and daughter avenue, but also making sure that many stakeholders come to these events and are bought into these events to really support community activity going forward. So I think I'll stop there. Thank you very much. And back to you, Anne, for questions.
Okay, thank you so much, Julie. We're actually going to go right to Isaac Adwole's presentation. We're going to keep all of the questions to the end. The last 20-ish minutes will be dedicated to a question and answer session. So thank you to those who have already submitted the questions. And Dr. Adewole, I see your presentation is loading. He is going to give a sort of perspective from on the ground, in this case, Nigeria, as it relates to reduction of cervical cancer. Dr. Adewole?
I believe you're on mute.
Isaac, we're able to see your slides, but we see that you're still on mute. Jenna, are you able to help unmute?
No, I can't if he's self-muted.
Okay. Isaac, if you're able to hear us, we can see your slide presentation loaded, but we need you to unmute yourself using the microphone icon that should be on the right-hand side of your screen.
I think I've done it.
We are able to hear you now. Wonderful. We'll let you go ahead with your presentation. Thank you so
I'm
much.
really very sorry about this. This is my outline, which I intend to follow. And following what Julie actually presented, managing cervical cancer in developing countries is faced with a lot of challenges, which are really listed on this slide, which includes lack of screening, late presentation, and inadequate facilities. And this is also a slide from Gavi documenting that many of the developing countries lack effective coverage for quite a number of reasons. So one of the things we need to do is to improve coverage in many of the countries. We also look at what has been achieved with maternal mortality, quite significant improvement, but really nothing has been achieved with respect to cervical cancer. And naturally over the period, there has been a 45% increase. And there's also little or no investment. We need to address the pipeline from community to this cancer center and make sure that we block all the leakages in order to ensure that we offer effective treatment to our people. In 2006, we launched an Operation Stop Cervical Cancer in Nigeria, which is actually a nationwide initiative to address the problem of cervical cancer. And we established centers of excellence in 6 institutions in the country, 2 in the north, 2 in the west, and 2 in the east. And this initiative actually was divided into 2 phases, a phase 1 and a phase 2. We were able to successfully complete phase 1, but due to logistic and financial support, we could not do phase 2. This initiative was generously funded by ExxonMobil Foundation, and it was a partnership between MD Anderson Cancer Center, the University of British Columbia, and the Rice University, as well as University of Ibadan. We also benefited from free shipment by FedEx. Most of the materials that we needed were shipped to Nigeria free of charge by FedEx. We conducted a training program, and we were able to train physicians as to how to do screening, how to do LEAP, and how to operate patients with cervical cancer. For phase 2, we thought that meeting the minister would be a good advantage. We need to improve access to chemotherapy, and also upgrade radiotherapy centers in Nigeria. This could not happen, but by some divine fortune, I became minister in November 2015, and I was able to address some of these issues which I had wanted to do under Operation Stop Cervical Cancer. I developed a 4-point agenda for my tenure as minister, and cancer prevention, treatment, and care happened to be one of the 4 initiatives that I consider to be priority. We looked at the challenges with radiotherapy, building infrastructure, putting more money in health, building capacity, and addressing the issue of the late challenges. We needed to improve the number of machines. As of that time in 2015, there were only 4 functional LINAC machines in the whole country. That means 1 machine for 40 million people, as against the minimum of 1 machine for 1 million people. We also needed to address access, the issue of funding. And we also looked at the low-dose brachytherapy machines. They were inactive. And we also had cobalt external beam that were functioning haphazardly. And in addition to that, we made a prescription as to what should be the future of all purchases in the country. We set standards in order to ensure that things were properly done. We reactivated the National Hospital in Abuja. We procured 2 LINAC machines. One was on ground for 3 years without being installed. We quickly installed it, and we secured the second one from Shell Nigerian Exploratory Production Company, and that became 2 machines at the hospital in Abuja. In order to ensure advocacy and bring the issue of cancer to limelight, we invited the wife of the president to commission the cancer center at the National Hospital in Abuja. Not only that, we started on a second project, which is a joint initiative of the Nigerian Sovereign Investment Authority, where a comprehensive cancer center was established at the Lagos University Teaching Hospital. Very functional, and we got the president to actually commission this second cancer center. But what was also unique, that apart from the president who was there to my left, there were 3 other governors who were also there: the governor of Lagos, Kebbi, and Kano. One of the governors immediately pledged to set up a cancer center in Kano. These are the active radiotherapy centers in Nigeria as of the time I left office last year. And then we have bunkers under construction in 5 hospitals in the country in order to improve our capacity for management of cancer. We also have some private organizations as well as state government promising and actually starting to invest in cancer center. As of about 7 of them are due to be commissioned over the next 2 years. Not only that, we have also addressed the issue of chemotherapy, the issue of choice of drug, the availability, the cost, and the regulation. We also improve quality of care. We keyed into the National Comprehensive Cancer Network. We established an African initiative, which was actually launched in Paris at the UICC meeting in 2016. And I co-chaired the African initiative to address the issue of quality of care in cancer management in Africa. As of today, there are over 100 cancer experts working together, and we've produced, at the last count, 46 treatment guidelines for Africa, and cervical cancer is one of them. We also address the issue of access to chemotherapy. We launched an initiative to reduce the cost of chemo in Africa. And not only that, 7 of our hospitals participated in this scheme, and it resulted in at least 4-fold reduction in the cost of these drugs. Not only this initiative has been expanded in June 2020 in order to make sure that we have more drugs. Particularly, we now have drugs covering the first-line treatment for cancer in Africa. We've also expanded the initiative. We call it Allied Against Cancer, bringing on board African Cancer Coalition, Clinton Health Access Initiative, National Comprehensive Cancer Network, American Cancer Society, and IBM. And we've also developed a navigator that will help clinicians practicing in their stations with respect to developing guidelines to manage cancer. What are the facilitators? Because these are quite important for anybody who wants to replicate what we've been able to do in Nigeria. One, we need a network of multidisciplinary working group. It is a long distance race. Nothing can be achieved overnight. Champions are needed. There is high level commitment and action at the top level. We need long-term funding. We need to build capacity. Data is critical, and international support is essential. Government has a major role to play, particularly in Africa. in order to increase the number of cancer centers, procure additional machines, and employ oncologists to work in these centers. We also made use of societies, training institutions. The Society of Gynecology and Obstetrics of Nigeria featured. The West African College of Surgeons was part of it. And the Gynecology Oncology Society of Nigeria also, in fact, organized a colposcopy workshop March this year. And now they organize a 2-weekly webinar on management of gynec cancers. NGOs are also important as well as individuals. In conclusion, I want to really join Julie to state that cervical cancer is preventable. Screening and vaccination are critical, but we need to build capacity to treat cancer because already we have cancer, but it requires meticulous planning and funding, and cervical cancer elimination is possible. I want to thank the following on my slide, and thereafter I want to call on Malin Tamena, who is a professor of Ops and Gynae at the Aga Khan University, Kenya, to make a presentation. Thank you.
Thank you very much, Professor Adibola, and I'm humbled and honored to speak after following two big leaders. Sorry for my voice, I have a bit a cold. Two big leaders in the field of cervical cancer, and the example from Nigeria really showing that with high-level leadership, one can make a difference. So my name is Marlene Temmerman. I'm an obstetrician gynecologist working and based in Kenya, in Nairobi at the Aga Khan University. And before coming to Aga Khan, I was director of the World Health Organization, Department of Women's Health and Research in Geneva, from where we also were very much involved in the cervical cancer, fight against cervical cancer. The advantage or the disadvantage of coming as the third speaker is that some of my slides will already have been shown, so it can go very fast. And you will remember that in the MDGs, we were aiming at reducing in MDG 5, reducing maternal mortality. We have not reached the MDG, but we had some success. However, looking at this data in 2015, cervical cancer has actually overtaken and is still overtaking the number of women's death in the world. So you see the other figures here. And as was said already by Judy, that women living with HIV are 4 to 5 times at greater risk to be infected and develop cancer. So women are dying in their prime years. Every 2 minutes, a woman dies from cervical cancer. I'm going to skip this slide, you have seen it, and I'm very happy to be one of the members of the Elimination Initiative Call to Action, the group called by Dr. Tedros, who indeed, as soon as he came on board, called upon everyone, the UN, the governments, the civil society, the experts, the academia, to join and to really kind of join efforts to make it happen. Now, strategic actions have been developed from WHO, and we know what is important is the health system enablers, surveillance, monitoring, evaluation. Partnership was clearly shown by the previous speakers, advocacy, communication. Indeed, you need the leaders of a country to be very visible and outspoken, but also you need the civil society to come along. And we have seen the slides as well. So we know that cervical cancer is preventable, and it is a low-hanging fruit. Why? We have time. It's not like you get your cancer today, your diagnosis today. We have time, primary prevention, secondary, and even tertiary prevention. And my topic is actually on screening and integration of this cancer prevention in existing reproductive health services. Why? We know countries in the West, I'm a Belgian, my country is doing not very well because we don't have population-based screening as opposed to the Netherlands, where every woman is really screened through a system from the government and through the involvement of the family physicians into screening. In many countries, including my own country, it's still too much opportunistic screening. And a lot of efforts have been done. In Kenya, we know what to do. So many organizations have provided guidelines. Even in, you see a publication that is, look at the year, 98, I was working in Kenya, and we came up with, the supermarket for women's reproductive health, where you would have HIVs, genital infections, family planning, and cervical cancer screening at one go. It works. It was a beautiful pilot. And you know what? The world in many, many places, I'm not talking about a great example from Nigeria and other countries, but very often we pilot and we suffer pilotitis. So now the question is, and I come back to that at the end, if we know very well what to do and we have the global community working and we have the leaders, how come that in many of the countries we are still in pilot phases? Again, examples from the country I know best, Kenya. Look at the date, 2004, we had already a very well established clinical services with mobilizing the women, the societies, the communities, engaging champions, 2004. We have published a lot, just, this is not comprehensive systematic review, but just giving you some of the papers showing that integrated cervical screening in HIV clinics. 2016, integrating HIV care services, family plan. So we know what to do. We have had call to actions from civil society. Again, same countries, Kenya, Nigeria maybe made progress. We are calling to action. We know what to do. I'm going quickly because of time, and we share the presentations. We have looked all these partners, funders, stakeholders, civil society, all working together, but still such a long way to go, because in Kenya now, only 16% of women in Kenya have been screened, despite the call from the ministry to have a minimum package. That was 2010. This one, 2019, is a national cancer screening guidelines. So we have the guidelines, we know what to do, but still only 16% of the women in Kenya in their life have been screened. We do a lot to integrate again. FIGO, international agencies, they are with us. We know again here other nice projects. I think I like this slide. Why? Because we have to involve leaders, but also men. How many men know whether their girlfriend, their daughter, their wife has been screened? Even in my own hospital, Aga Khan University, we have the Aga Khan University Hospital. We are doing now research asking our own healthcare providers, doctors, gynecologists, specialists, nurses, admin. We are asking them, how many of you went for screening in that age group? I must say, very disappointing. And they are the ones highly educated. They don't miss, you know, they are insured. They have access to healthcare. They are not poor women in a rural area who don't know what to do, where to go. So we also ask the men. So how many of you know whether your wife, your daughter, your sister went for a smear or HPV or whatever? And I must say it is very low. One other story besides I think in the building blocks that we know very well from WHO, the 6 building blocks, looking at provision of healthcare, we also have to give more attention to the perception of the community. And just to end with one story of my own clinic as a gynecologist, seeing a woman in her late 40s, mid to high level class. She has insurance, she has everything. She comes to my clinic with spotting. So I do the exam. She had a smear, she said, somewhere else, maybe 3 years ago. So I do the exam. She had just some postcoital spotting, nothing else. And I see that she has a cervical cancer. So we take a biopsy, we do a staging, and I give her an appointment to come because she was still manageable. I mean, still in that stage that we could do surgery. She didn't show up. So I thought maybe she has gone to another healthcare provider, second advice. So I called her. Maybe she misunderstood. And there she is on the phone, this quite high educated woman. And she said, Dr. I understood very well. You were very nice to me. You explained very nicely. It's not a problem of money, but I'm not going to tell my family that I have this cancer. Because this cancer, this woman cancer, it's not something I can tell my husband, my mother, my family, my children. I rather die with my cancer than involving my family. So, I mean, it's just a story to show it's, of course, we need facilities, we need the money, we need the HPV vaccines, and for the young daughters, but we need much more. And in Kenya, the president has launched a couple of, you have seen a slide, a couple of months ago, the HPV vaccination program for the young girls, coming with the moms for the screening and so on. Very high visibility. Aim is to vaccinate 800,000 young girls per year. We are reaching 400,000. Why? Because there is a lot of pushback from churches, from community groups, from, you know, who are saying that vaccination is bad for the health of the young girls, introducing or supporting promiscuity and so on. So there is an action against it. And this is also something, if we go for that, we have to think about, and not only about the pure health kind of interventions. I think that was my last slide, just to recognize that the world indeed is, as Julie said, taking leadership, and there was a lot of it. You have to go to the website of this universal health coverage cancer, because universal health coverage is now very high on our agenda. But how do we integrate cancer, and more specifically for this, are cervical cancer prevention and treatment in the UHC program? Thank you so much.
Wonderful. I'd like to just start off by saying, first, thank you to Julie for presenting sort of a high-level overview on the WHO Global Control Challenge, and also to Isaac and Marlene for talking about their program strategies, success, and also challenges in working towards the ambitious goal of less than 4 cases per 100,000. I've been reading through the questions, so I just am going to make a few broad comments before we get into some for our individual speakers. First, new innovations and technologies were raised across the presentation. So I just wanted to call your attention to our next webinar, where we're going to specifically talk about some of those innovations and technologies and their role in global reduction of cervical cancer. And then a lot of talk and questions around sort of implementation and delivery challenges for vaccination, for screening and for treatment. So I want to call your attention to our third webinar, our final one in the series, which will be focused on the role of implementation research in helping us achieve these broad goals. One more administrative note is that this webinar is being recorded and it will be available online, both on the NCI website and on the CUGH website, and we can be sure to share that link. So I think with that, I will get through some of the specific questions, but I also want to throw one out there, right? So this webinar series arose because of the COVID-19 pandemic, right? This webinar series is a combination of sessions from both the NCI Global Cancer Research Symposium and the CUGH annual meeting, and it was moved onto these virtual platforms due to COVID-19. So maybe somewhere along the line, we can get some comments about how this pandemic and moving into a quote, new normal or new abnormal state is gonna affect all of these challenges and activities and how we can respond. I'm gonna put that one out there just so as we give our answers, we can also individually keep that in mind. But first, a specific question, and I think it relates to COVID-19, and I think just broadly to the challenge. Julie, a question from your presentation, but it really is a global question, is when and where will funding be identified? And then also a question about the use of HPV testing. So this relates to funding, but also availability, and how can we make HPV tests available and affordable across our LMIC, since it's central to the WHO challenge?
Okay, I mean, funding's always a challenge, and of course it's going to be increasingly a challenge in our post-COVID world. So I don't want to minimize the challenge that funding poses. But I think what the universal health coverage movement is really trying to do is to encourage countries to think about making the most of the domestic funding they have. Marlene mentioned, we've done a lot of piloting, we've got bits of projects here and there, but are they as effective as they could be? If we're screening women but not following them up, that's a waste of money, as well as an opportunity to potentially save a woman from cervical cancer. So I think the first challenge is to really look at domestic funding and so how can we optimize that? And can we use this global push on elimination to really make the case, not make the case that we should do more screening, more vaccination, but show that by doing that and shifting to prevention, shifting to early detection, we actually save money. We save money in the system, and we create thriving families and women that can contribute to the communities moving forward. So I think there is that overarching investment case that still needs to be made more strongly. And I do know that the group that's been working on the modelling to show how elimination can be impactful on low middle income countries, they're also now adding in cost and cost effectiveness study across that model, and will be publishing that data and the global investment case by the end of this year. And I also know that if you'd like to request your own national data from WHO, they are able to provide some of that information to countries, but you will have to get your Ministry of Health to request that information from WHO. So that's the one part of the solution is getting the budget working as optimally as you can locally. We've had a great announcement just this past month from Gavi of 84 million doses being pledged to the next cycle of Gavi work. So we know that there is HPV vaccine available through the Gavi mechanism for low-income countries. So those that haven't yet introduced, or those that are starting to introduce, they can move forward knowing that will be available through Gavi, that support. And we know that middle-income countries are struggling for financing vaccination, and Gavi has looked at some leveraging their expertise to help middle-income countries, both with upfront financing of their vaccination program and also longer-term forecasting, so that they can negotiate better with the manufacturers. So that's some opportunity there. And then on the HPV test, well, WHO has a number of working groups that have been underpinning all of this work that's been presented, developing the strategy and the targets, but also some very targeted working groups looking at each of the aspects. And one of them is screening and access to HPV tests. So there is an express process looking at pre-qualifying the tests. We have a unit aid investment in a number of countries, both through Expertise France and through CHI, to help countries in high burden settings to introduce the HPV test and set up systems, building on the laboratory infrastructure that we have for HIV, for TB, and really show that the HPV test can be used well in lower income settings and start to build that demand, and therefore encourage manufacturers to get involved in this space and bring their price down. So whilst it is still quite a costly investment up front, I think we'll be able to see a more emerging data from low middle income country settings to show that the HPV DNA test will help alleviate so many of the challenges of implementation that also Marlene was talking about earlier, enabling a much closer engagement of women, but also a distribution of the service through the e-health and through training of primary care health workers to work with the self-sample, for example. So I think that there's a lot of challenges, but I think we should be excited about the opportunities. There's some great research in different areas showing the best practice, and we need to take that forward to policymakers. But I think the first challenge is really to get them, one, invested in elimination, and also updating all of those plans and activities to really try and maximize the opportunity that elimination shows. And I think that will attract more of the international donor activity into this space. It's a great opportunity to show integration works, to build on reproductive health services, to build on HIV services, but we need to show donors and get them interested.
Yeah,
hope that answers
that's a great
bit.
Yeah, and it's a great transition to the next question that we have, and this one is going to be geared towards Isaac. It's sort of a two-part. One was a clarification about whether the program in Nigeria right now is population-based screening or is still focusing on opportunistic screening. The second part then is whether Nigeria has done any budget impact modeling to really look at sort of the cost to the whole system. So moving beyond cost effectiveness to make relative decisions into a full budget impact analysis. Has that been done? Would that be helpful when we think about combining the financial aspects with the implementation challenges?
Thank you so much. The first answer to the question is that we are still doing opportunistic screening in Nigeria. We do not have community-based screening at all. And I think it's the same for many African countries. We are yet to get population-based screening entrenched. As regards budget impact analysis, we are yet to do this. What we've done actually is to look at cost effectiveness modeling, where we try to look at what should we do, which one will be best for Nigeria, one screening with one dose of the vaccine. And we thought that is one screening done with one vaccine will be quite better than doing nothing, and will also be will achieve almost the same as when you do 2 or 3 screening per lifetime, or when you give 2 or 3 doses of the vaccine to the client. Thank you.
Great, thank you. And then just a final question. I think that this one is going to first be geared toward Marlene, and I think it's a place where you can sort of comment on what our new normal would look like. First, I love the term pilotitis, and we had a couple of comments expressing that as well. And as Julie mentioned, it's really, you know, how we are going to go from these pilot projects to work with the resources we have. We have a lot of questions about scale up. I think this relates to your integration. One of the questions was, what are the barriers that you are seeing to successful scaling up of programs, right? How we go beyond the pilot programs. And I think that that is important, has always been important, but particularly now when you're looking at the interface of a lot of health domains that are being impacted by the ongoing pandemic.
Sure, thanks for the question. In many areas, scaling up is a problem. But as Julie was saying, we have an intervention now where we know, compared with breast cancer, which is much more difficult right now. Many women are dying of breast cancer, but the screening, the prevention, that also has to be addressed. But for cervix cancer, we know how to prevent, we know what to do in all these different phases. So we are ready to scale up. We can learn from the successful pilot projects. And I think what is needed, as Prof. Adewola said, once in a country you know what works, then you need, under the leadership of the Ministry of Health, you need a strong ministry supported by stakeholders, partners, to really invest and make it happen, together with community mobilization. And it has been shown in Nigeria and other countries, it can work. Of course, money is always a problem. And competing now with the COVID funding is even making it worse. But having said that, there is always kind of a way out. We haven't addressed, because that is a topic of the next sessions, like the self sampling of HPV. So there is an opportunity to kind of show the women how they can do it. It has to be tested. We need more experience, but on a community basis to make sure that women can self-test, that we can bring it to the lab without kind of extra costs. So there are models that we could try to scale up, and there are donors and stakeholders who are willing to join us, but it's a matter of leadership. And the community mobilization and the community awareness is crucial. And I think it's the same in Nigeria. You need to take time to really sit with the community leaders, to have their buy-in, their understanding. And you know, it is still very much connected, everything with HPV. First thing that the community leaders here are asking, is this a sexually transmitted disease? Of course it is, right? HPV. But if you focus on that, then it will be kind of categorized. So we should not delete this from the health education, but not focus all the time. So we should find local language, local messages that in the country that you can, because there is a lot of pushback. I don't know in Nigeria, but here in Kenya, there is a lot of pushback to the vaccination program, to the screening program because of that. And the other thing I want to underline what Julie said already, setting up a screening program, be it via HPV, we all are convinced that HIV is the way to go, and we will be able to lower the cost. That has already been shown. Think about HIV 25 years ago. We were convinced that there would be, the treatment would be much too expensive to come to Africa. And thanks to volume and price and all kind of negotiations and having everyone working together, HIV treatment is a reality. So we can have the same lesson learned from the HIV/AIDS community to leverage cervical cancer, but investing in screening without treatment of precancerous lesions and of cancer is, in my view, unethical. We have so many women who came for screening. They were told something is wrong, and then, nowhere to go. They just gave them time to develop their cancer. So an extra burden on the shoulders of the women. A screening program is absolutely needed, but has to be developed together with, as was said by the other speakers, with treatment. Thank you.
Yeah, I think that's a wonderful point to end on that was iterated across the webinar today, is making sure that we're coupling our screening results with effective full coverage treatment programs. We are out of time. I just want to call attention to a really great question that came through that we can all sort of think about in the interim, is what is the role of advocacy? How can we be better at it, both for our screening and for our treatment and vaccination programs? It can be a webinar in and of itself, but I did want to put it out there so that we can all think about it. I think it has an enormous role in making the most of all of the efforts. Just one final point today, we did have two speakers about programs in sub-Saharan Africa. That was just by coincidence, and if you join our other webinars, we have speakers from other world regions, including Central and South America. Obviously, they're shouldering a large burden of cervical cancer as well, and in fact, two speakers from Central and South America will be in webinar 3, focusing on their implementation research programs. So with that, I want to thank everybody today for their participation, both the speakers and the attendees. Our next webinar, the second in the series, will be the same time next week. So that will be Wednesday, August 5th. And we really hope to have you all join us then. So with that, I want to say thank you so much, and we look forward to seeing everybody next week to continue the conversation to reduce cervical cancer globally. Thanks so much.
Thanks, everyone. Bye-bye.
Thank you. Bye.
Bye.